So anyway, it's 5 o'clock in Copenhagen. So it's time to get started on the webinar together, apart, at home. And we have been in different people's homes. We have visited Carrie Jones, and we have been at Richard Lord's home and seeing his view. And we visited Tom Fabian and his work office or home office. My home office here, and Miguel, and yours is really exciting. I think it's beautiful colors and very, very nice.
Thank you. Yes, it's just my home, not just my home office. It's everything in one place.
So nice. So I'm Anne-Catherine, for those of you who don't know me already. I am the co-founder of Nordic Laboratories and DNA Life, together with other partners. We are a group of companies that are dedicated to functional medicine, dedicated to providing tools to help people feel better, to help them for a better journey towards health optimization, you can say. What we talk about here, you are able to purchase in our profiles because you have been invited. You should already have a profile where you log onto and you can create your patients there. You can order lab tests, you can even order supplements and so on in there. And what you can do in one order is to put in both a Dutch, both a GI map, and organics, a SIBO in one go. So you're working with, you can work with several labs in one order, which is really nice. And you only need to go to one place to get the results on the patient, which is into the patient's profile in your own profile. So enough of that practical stuff. Then I will move on to the next webinar next week. Same time, same place in the world, at home. It will be on fasting mimicking diets, specifically on Prolon, a very important component in our functional medicine toolbox. So I hope you will join us then as well. And then, of course, I am honored to welcome Miguel for the next hour, where he's gonna talk from his heart to your hearts. And yeah, Miguel is a member of the Nordic family. He is a medical doctor in the Nordic clinic in Portugal. We have a Nordic clinic in Copenhagen, one in Stockholm, one in Finland, and one in Porto. And there will come more. There are some babies on their way, maybe. So yeah, so Miguel is kind of, yeah, a family member, you can say. And the interesting thing with Miguel is that he is very kind. He's very compassionate. He thinks about how patients perceive things, even like how he's sitting now. He's thinking about how does the patient feel comfortable in speaking to him and so on. So yeah, that's a real personality who's going to talk to you now. A compassionate functional medicine doctor and a compassionate second generation functional medicine doctor, because Miguel's mother is the godmother of functional medicine in Portugal, and he has basically been breastfed with functional medicine, and he lives it, and that's what he's going to show you now. I would say that what's going to happen now is you will be taken through a symphony of functional medicine, because we're not just talking one test here, we're talking the whole shebang. Enough from me. I will pass on the stage to Miguel. Miguel will share his screen, and yeah, as always, put questions on the side. Humbly, I will try and answer them on the side, and I will pick up what I can't answer, or if I think Miguel will be a better person to answer it on the way. So thank you very much, Miguel. Here you go.
Thank you so much for your introduction. I'm kind of nervous now, and it's fantastic to be here and to be able to share with you this topic. And I will just share my screen. I think you should be seeing everything now. And thank you all for being here. Thank you all for taking the time everywhere in the world, from east to west, from north to south, to be here. It's my absolutely amazing pleasure. And as Anne-Catherine was saying, I'm a medical doctor in Portugal. I run the Nordic Clinic in Porto, and we have my heritage. It's my mother's clinic that we are I'm in charge of it after she passed away. And what you have to understand for taking into perspective the next hour or so is that I am just a doctor. And the reason I tell you this is because we've been seeing, and if you had a chance to watch the previous webinars, you can see that we have been amazing people, doctors and researchers, and on very specific topics. So I'm not an immunologist. I'm just a doctor that wants to make sure that my patients have the best treatment possible. So we will not discuss the ins and outs of immunology, the receptors and the enzymes, and it will be more of a clinical approach, of a step-by-step clinical approach that I use, that starts always with why. But because I'm Portuguese and our brains are not completely polite all the time, it usually morphs into a more passionate question. And then it also divides into three others: when, what, and how. And if we think about functional medicine in a more formal way, these kinds of match with what we call the antecedents, the triggers, and mediators. But the bottom line is why. And when we start asking why, and if we follow through enough whys, we'll be able to reach the bottom question and understand what our patient is suffering from and what everything is about. So my plan for today is to talk about the diet, the microbiome, vitamin D, genes, and then what I call the common factor. So let's start from the beginning. And autoimmunity can be defined like this, and basically means that we lose self-tolerance. So we start understanding our cells, our molecules, our proteins, our receptors, as not being our own, and we start attacking them. So to lose something, we have to gain it. And we start gaining tolerance, well, when we are developing ourselves in utero, and then after, both in a central way. Basically, we scan what is going around, and start seeing what we should not attack because they are good things, or what we can attack because they are not good things. And then it goes from a more central perspective in the thymus. It goes then into each tissue, because each tissue has different types of proteins, of cells, and so on. And it is the end result of this beautiful process that will gain our self-tolerance, and we'll be able to identify what is good and what is bad. In a more simplistic scheme, we can see here that the development of the different immunological lineages in the different T cell lineages starts with the antigen presenting cell, that it morphs into the pre-Th1, the pre-Th2, and the pre-T regulatory cells. And then this precursor will lead into T regulatory cell and Th17 cell. And this is absolutely critical to understanding everything about autoimmunity, that we understand this, that T regulatory cells will decrease autoimmunity, and Th17 will increase autoimmunity, because all autoimmune cells, all autoimmune disease, or most, if you want, we don't want to use all, but most, they have all this Th17, which is driven by interleukin 17 active. And you have to see this Th17 as a mad person with a machine gun out in the street, just shooting everything. And the different type of building, the different type of structure, whatever the bullet will hit, will be named a different disease. But the core, the Th17, is the same. And when we think about functional medicine, we don't care that much about where the bullet is hitting. If we get rid of the person shooting, we will get rid of the problems. So autoimmunity is like this big battle between Th17 and T regulatory cells, which that's called the maestros of autoimmunity. They are the regulators. And in functional medicine, as you all know, autoimmunity or anything immune will start in our lovely gut. And it starts with the development of the food intolerance. And it goes like this: the antigens go into the gut, they are absorbed by dendritic cells, which are one type of antigen presenting cells. They go into the lymph nodes, they are presented to the T naive cells and the B naive cells. And depending on all the cytokines and all the environment that we have there, they will be developed into proper T regulatory cells and proper Th1 and Th2 cells, and we'll have a very good oral food tolerance, meaning foods will not trigger any serious immunological reaction. So the question is, so what? Why does this matter in clinical terms? And I bring you four clinical cases from our practice here in Portugal on autoimmunity. And let's start from the first one. And the first one, when he came, he was 8 years old. He was on second year in primary school. He was son of divorced parents, but the best divorced parents that I've ever seen. They are pretty friendly. So no big trauma on that, but kind of. And he was healthy until 8 months before coming to the clinic. And all of a sudden, he started developing non-specific arthritis with sacroiliitis, knee pain, fatigue, anxiety, all that you can expect from a non-specific arthritis. In terms of blood markers, he had the normal inflammatory ones, and symptoms improved with corticoids. When I started asking about what else would we be talking about in terms of the child, the parents said that 2 months after starting primary school, he developed rhinitis and a mix of constipation and diarrhea. So I started thinking, and we have to ask why. And what is intriguing about this case is this. He was on second year primary school, and something changed 2 months after starting primary school. And if we look into our own data, we can see that children with recurrent infections, allergies, and GI changes, no matter which ones, no matter if it is tonsillitis, otitis, cystitis, or if they have eczema or asthma or diarrhea or bloating, they usually start to have those symptoms or those conditions when they are 6 months old, 12 months old, or between the age of 3 to 6 years old. And if we ask what is common about these different ages, it's the diet. In those different ages, children are supposed to have their diet change. At 6 months old, they are supposed to start introducing foods on that scheme, let's say. 12 months old, they are supposed to start eating normally. And between the age of 3 and 6, they enter kindergarten or primary school, and they usually start snacking. And indeed, this boy fitted into this group. And indeed, what seemed to have been the trigger of all this was diet. And even though this is not an actual picture of the breakfast in Portugal, it is the actual picture of the breakfast of children and the snacks of children in Portugal. Is sandwiches, is milk, and actually, I don't know where you live, it goes like this, but in Portugal, children are it is kind of mandatory that they drink the milk the authorities give to the schools. Otherwise, it is a very big problem to justify that. So what's diet leads into? It leads into what we kindly describe as leaky gut. If this is a healthy gut and we have this integrity everywhere and the system is working perfectly, then foods will not be a problem. However, the problem is then when we start ingesting foods that are either different types of food or in different quantities, we start having increased permeability, especially for larger proteins. And this increased permeability will let things in. It will trigger not only a local inflammation that will worsen this inflammatory reaction and allow a more leaky gut, but also it will spark systemic inflammation and no chronic low-grade systemic inflammation, saying, I usually tell this that we start having radio information in all our country that we are being attacked somewhere in the other, in an extreme part of our system. So this, in terms of arthritis, will trigger Th17, and Th17 will lead to inflammatory arthritis. So if you use the modus operandi of functional medicine in this case, we have to test the hypothesis that the cause is food. And that's what we've done. We've tested it with the Nordic Food Panel test, and it is in Portuguese, sorry, but you can see basically that we had a lot of reds. On your right-hand side, you can see eggs, either yolk and whites, they are positive, and everything else is milk. And on the left, gluten is self-explanatory, and the last one is wheat. So thinking about the average snack and the usual snack that this kid was having, it was exactly what he was being intolerant towards, and it was sparking this inflammatory reaction. And then the nutrition plan was quite simple. We look into the diet. Our nutritionist, Daniela, which is very experienced with these cases, planned the diet, age adapt, and 6 weeks after, he had no pain, no physical limitation, and all blood markers were normal, which is kind of astonishing because he was, I mean, the summer prior to the first appointment, he could not play with his mates because he felt so much pain. So it is a very good case, but, and it is a very big but, diet changes may not be enough. And let me present you another patient of ours. He was a 23-year-old man. He worked in finance while he was doing an MBA and some post-graduation, and he was healthy until 1.5 years before coming to my appointment. And all of a sudden, he was diagnosed with Sjögren, and it was a very severe case of Sjögren because he could only stay 5 minutes looking into a screen without needing drops. And for someone working in finance and studying, it was having a very serious impact in his life. He was having also severe constipation, severe bloating. And one interesting thing he told me, that he was sensitive to gluten, sugar, dairy, some vegetables, and some fruits. In terms of the analysis, everything you can expect, he only had mild improvement with corticoids. And one thing very interesting that helped me solve the case was this, that he tried non-conventional treatments, especially in terms of diet and supplements, and every time the path was like this. He had initial improvements, and then 6 to 8 weeks after, it started getting worse again. So let's put our thinking hat and pause and ask ourselves a question. In terms of these gut issues and this link between gut and inflammation, what truly creates the problem? Is it the foods that are creating the problem, or the problem is created by foods, particles, proteins coming into the system? And if we want to go deep down, it is the particles, the proteins that create the system. And the problem is barrier dysfunction. And in terms of barrier dysfunction, and we think around these lines, the first case and second case are very, very different. Because in the first case, we had a clear cause-consequence link between food and symptoms. And also in terms of therapeutic proof, when we removed the triggering foods, the symptoms went away. But on the second case, it doesn't seem to be like that. And that's a difference in what I call the primary food sensitivities and secondary food sensitivities. The primary ones are in cases in which the food is a primary agent in creating this inflammation. Now, in the second case, the food sensitivities are already secondary to something. That's why when you change the diet, it gets better, but then gets worse, because it seems that something else might be going on in this body. So I asked him, what I ask all my patients, what do you think, why do you think you have what you have? And he said, well, doc, thank you for asking that question. I've told this to every doctor and healthcare practitioner that I've been to, and no one seems to pay that much attention to it. But I took ciprofloxacin 3 days before the onset of the symptoms. So there you have, that's the key to his case. It was clearly dysbiosis. And indeed, in the initial assessment, we already knew that he had some issue with probably dysbiosis. These two are pretty common symptoms in such cases. And indeed, we have a plethora of reasons why change in microbiome can lead to autoimmune, either microbial composition or the epigenetic changes that these dysbiosis trigger that are pro-inflammatory, or the aberrant immune responses that it triggers. But at the end of the day, by definition, any immunological driven disease has to be linked to the gut. And here you can have a side-by-side comparison between what would be an homeostatic status and then an autoimmune disease, when we have the dysbiosis changing methylation and acetylation of our DNA that will impair the proper immunological development. And you can see on your on the bottom right corner that battle between TH and T regulatory cell being messed up, and that being the reason for the autoimmunity. So we did the comprehensive stool analysis parasitology to this patient, and truth be told, he didn't have any infection. However, he didn't have either many good bacteria. As you can see, this was one of most extreme cases that I've seen of lack of good bacteria. Had no bifidobacteria, no enterococcus, and very tiny amount of lactobacillus. And the only other change that he had was a very low level of butyrates, both linked with autoimmunity. So butyrate. So when we go review the data on microbiome changes and autoimmunity, we can have indeed a representation or proof that some strains are linked with some diseases. My clinical opinion is that this is a very big environment, and it is the change in the environment that will create the problem. And these specific strains do have some importance, but in the big scheme of things are mild. So what we did with him was recover his microbiome through these supplements. The first two, so the first one is one of the most complete probiotics. The second is the only one, to my knowledge, that has enterococcus. The Biotagen is a prebiotic, and then some what I called anti-inflammatory support. I could have prescribed a very different choices, but these were the ones that I chose for his case, especially magnesium because of the constipation. And after 8 weeks, he got better from the Sjögren's and the gut function. And after more than 2 years now, he's pretty much recovered. And he felt that it changed so much his life that he dropped his career and has just finished a month or two ago his certification in functional medicine coaching through FMCA. So we have reviewed everything about the gut, and usually this could solve most problems. Now, no matter how good or bad job I did linking gut, diet, microbiome, and autoimmunity, it has a fundamental problem. And the problem is that epidemiologically, it doesn't make that much sense. And let me show you this data from Sweden. And I chose Sweden because I could get this data, and it's Scandinavian, it's Nordic. And you can see on the right-hand side, some inflammatory diseases, so diseases that have an inflammatory basis, and on the right-hand side, autoimmune diseases in terms of prevalence. And as you can see, they are very, very different. It's an order or two of magnitude different. So what does this mean? It means that something else must be going on, because if it was, you cannot have the same cause in creating so big of a difference in terms of the prevalence of diseases. And then when we look worldwide in terms of the distribution of autoimmunity, we kind of see a pattern. And the pattern is, the longer you are, or the further away you are from the equator, the higher the values of autoimmunity. And in multiple sclerosis, it is quite clear. So let's compare with another graph. If you put vitamin deficiency in the world, you can see that they match very well. And this was the first step to a very long chain of events that led to the demonstration that vitamin D has something to do with autoimmunity. So let's talk about vitamin D, which is a steroid hormone. It's not an actual vitamin. It was called vitamin because it was the fourth vital element to be discovered, and it goes through this pathway of activation in the skin. Then the liver gets the first hydroxylation, the kidney gets does the second hydroxylation, and we have the activated vitamin D, that's calcitriol, that's the 1,25-dihydroxy. And this is the classical functions of vitamin D, and it is described for ages in terms of bone formation and calcium balance. The problem started, or the good problem started, when it was discovered that especially the second enzyme, that second hydroxylase, that we thought that only existed in the kidney, they exist everywhere. So that opened the door to the new functions of vitamin D, that most of them are immune. So vitamin D works by making sure that the transcription of DNA is optimized. The first step of the transcription of, depending on the papers, this paper from Dr. Hollick, or in his book, said 6%. Other places I've read 20% of the DNA needs vitamin D to be correctly translated. And one of the type of cells that needs the most and benefits the most from this vitamin D is the immune system. And in terms of autoimmunity, it has been quite clear. It has been published that calcitriol inhibits interleukin 17, which drives Th17, and that vitamin D and vitamin D receptor are the critical regulators of this axis, Th17 T regulator, this battle. So vitamin D can have a direct impact in immune cells by lowering Th17 and increasing T regulatory cells, amongst other functions. And you can see that these two steps are exactly what we are looking for every time we approach an autoimmune condition. But the second is that vitamin D can have an indirect impact on autoimmunity through the gut, because it is critical to shut the door in the leaky gut and optimize the local development of immune cells. Specifically in this way, what has been shown is that no matter the big picture in terms of cytokines, when we don't have enough vitamin D, the pre-T regulatory cell will be developed, or will develop to Th17, and by definition, it will be at the expense of T regulatory cells. So that's why vitamin D is so critical. Vitamin D, if we don't have it, will have this effect that I show here: more autoimmunity and more autoimmunity. So vitamin D, active vitamin D, has a clear suppressive effect on autoimmunity, doing these both things. So we can conclude that low levels of this hormone are critical to autoimmunity. And indeed, it has been published for a long time now. We can show papers published in regards to multiple sclerosis, psoriasis, lupus, rheumatoid arthritis, you name it. So I can resume all evidence to these two effects. Either when we don't have vitamin D, we have a higher incidence and prevalence of the disease, or we have a worse clinical outcome. So one question that we can ask is how much vitamin D we need. And the absolute minimum is 80 nanograms per milliliter, taking into consideration that we have the usual reference range is between 30 and 100. So let's look into the recommendations, the recommended dietary allowances, the RDAs. And I hope I'm not the only one thinking that these and these don't make sense together. It just doesn't make sense from any point of view that a child with 1 week of life needs 400 international units of vitamin D, and an adult needs 600. Even in a by weight perspective, it doesn't make any sense. And indeed, it has been proven, and I cannot explain you the math behind it, but I have here the papers, that the correct RDA dosage should be 8,895 international units of vitamin D per day. So it matches what the European Food and Safety Authority said in 2012, that 10,000 international units, which is 2,550 micrograms of vitamin D per day, was established as a no observed adverse effect level, meaning anyone, this for adults, and especially for people with more than 50 kilos. So if you know nothing, and if you weigh more than 50 kilos, you can take 10,000 units of vitamin D per day safely. So we arrive at another problem, is that even though there is a direct link of vitamin D and autoimmunity, it doesn't explain the scenario, again, epidemiologically. Because if we look into the epidemic of low levels of vitamin D in the world, we see that most Western world, and not only the Western world, have low levels of vitamin D. And if we think that we need to have our skin in contact to the sun, and without any shield, either any sunscreen, any clothing, or any glass to produce vitamin D, I mean, we basically, the Western world lives inside an office, a house, a car, and we don't spend that much time outdoors. So that's why we have so many people with the low levels of vitamin D. Now, if it was only a question of having low levels of vitamin D and you would have, or you would be diagnosed or would suffer from an autoimmune condition, we'd have to have many more people with autoimmune condition. And thankfully, that doesn't happen. So what next? And next is our DNA. And we can look into our DNA and find very interesting answers. And there's plenty of research around this topic. And what have been founding is not cohesive. We can see some genes being related with some different diseases, but that doesn't seem to have, like a genetic trademark or a signature for autoimmunity, unless we can find it on vitamin D, because I have just shown you that vitamin D itself can have a huge impact on autoimmunity. So this was a paper published lately, I think it was 2015, from my very home university, the University of Porto, where I graduated, that studied the link between vitamin D receptor polymorphisms and the severity of lupus. And what they found is that vitamin D receptor polymorphisms were linked with higher lupus severity, with worse prognosis, and a risk factor for cumulative damage. And if you start digging in, you can find the same type of evidence in many autoimmune conditions, from Crohn, colitis, from multiple sclerosis, rheumatoid arthritis, even thyroiditis. So in the absence of vitamin D receptor, we have an increased production of Th17, increased Th17 responses, reduced T regulatory cells, and reduced telomorogenic dendritic cells. Basically, vitamin D receptor expression is crucial for the regulation of this T regulatory cell Th17 balance. So this interleukin 17 is directly repressed by calcitriol, which is this 125 is the active form of vitamin D. In the paper, this concludes that the repression was stronger in the presence of vitamin D receptor. Thus, vitamin D receptor is a limiting factor for the suppression. And what happened is, when we cannot attach vitamin D to its receptor, and also the machinery involves the retinol X receptor, we cannot complete the proper development of the T cells, and we'll have less T regulatory cells, and by definition, more Th17, therefore more autoimmunity. And there are different SNPs. SNPs accounts for single nucleotide polymorphisms. So they are very, very small genetical changes that they are not enough to create a big mutation, a catastrophic mutation, but they are enough to change, in this case, the three-dimensional configuration of the receptor, therefore creating some type of problem. And we can see those in DNA health. And basically, when we change the conformational assemblies of the VDR, we change the genetic expression and the regulation and the genomic responses that follow. So having these SNPs just mean that we have a vitamin D resistance. The vitamin D that we have in our body will not lead into a proper response. So it's not that low levels of vitamin D are crucial to autoimmunity. It's more a case that low levels of the real biological effect of vitamin D are crucial to autoimmunity. And again, let's ask, so what? Why does this matter? So let's look and take the imagery of a dam. And the dam is quite a good comparison, because upstream we have the normal river flow, but then we have a resistance to the flow of the river. And if we want to have the river continuing downstream, we need to have enough water upstream before the dam to overcome the resistance, to overcome this barrier, and make sure that it can go on towards the sea. So when we think about this configurational changes and the SNPs, if we increase vitamin D intake enough, we will correct, with air quotes, the effect of the gene polymorphism. We will optimize the genomic response, and in terms of what we are dealing here, we'll get a better T regulatory cell to Th17 ratio. Therefore, the ultimate battle will have a more positive outcome. So what I'm trying to say is that high dosage of vitamin D can indeed treat autoimmune conditions. And I'm very fortunate to have met Professor Cesar Coimbra in São Paulo. He's a brilliant neurologist with a PhD from Lund University, or a postdoc from Lund University, that by chance, and literally by chance, he discovered that vitamin D could have a massive impact and improvement on autoimmune conditions. He was treating a patient with Parkinson's or recovering from a stroke. I don't know specifically which one, but he had a vitiligo patch on his forehead. And because of the blood work that he ordered, he noticed that he had low levels of vitamin D. So he supplemented with this 10,000 units of vitamin D. And 3 months after, when the patient returned to his office, he asked him, "Oh, sorry, sir, I have written here that you had a patch of vitiligo. Where is it?" "Oh, actually, I don't know. It just went away." And because he was a researcher and quite a curious one, he started digging. he understood that vitamin D could, let's put it mildly, help to solve autoimmunity. And he started a process of tweaking until what we now know as Quimper protocol that I've been prescribing for more than 5 years now. And the Quimper protocol has these 4 legs. The first one is high vitamin D. So how high is high? So the starting dosage is 1,000 units per kilo per day, and then we adjust afterwards. We also use omega-3, magnesium, and vitamin B2, but the main player, the star of the company, is vitamin D. And he was allowed, Dr. Cicero, Dr. Professor Quimper, applied to publish few papers on different autoimmune conditions, and he was only allowed to do so in vitiligo and psoriasis. And it was a very small study and was a time limited, and dosage of vitamin D was fixed, was 35,000 units per day for 6 months. So I would ask you to think about what would be a good result for this study to have, for it to be considered a very good therapeutic option. And these are the results. 14 out of the 16 patients shows 25 to 75% of repigmentation. So truth be told, no one recovered completely, but it's fairly good. And have here, these pictures are published in the article. In terms of psoriasis, we had 100% of patients improved. Not 99, but 100, which is fairly good. And have here the pictures that were published. From my experience, this is a very, very, very good scenario. We don't get this that often, but it's still a good result. So the question that we have to ask, and we ask ourselves while we're doing the Green Protocol, is how do we evaluate the real biological effect of vitamin D? So let's go back to the dam. If you want to evaluate, if you cannot measure the height of the water or the height of the dam, the best marker to see if you are having enough water prior to the barrier to make sure the river flows is just measure the water in the river just before it goes into the sea, because that will be the end result of all the dams, all the barriers that the river can find along the way. And we use it, or we use the balance of calcium in our body, because it is a very interesting balance, and that is very useful because it is like an old scale, a two-side scale. I don't know how we can call it this, let's call old scale. In one side of the scale, we have the real clinical or biological effect of vitamin D, and then it inversely affects parathyroid or parathyroid hormone. So it goes literally like this. If we want to have the maximum vitamin D effect to reach the therapeutic goal that we need, we have to have the minimum PTH, because no matter how much vitamin D you have, PTH will measure the downstream effect. So low PTH or very low PTH will mean maximum vitamin D effect, which means an improvement in the ratio T regulatory TL17, which will mean low autoimmunity. So you can see that that's what we aim for. Low PTH driven by vitamin D, because it will be the end result and will be the best marker to assess if we are winning the battle of autoimmunity. For all of you that were quite shocked with this, indeed, there's a thing called vitamin D toxicity, and it is quite severe. You can see here from Medscape that it can lead to, I think this list is quite mild. We can find much worse consequences of vitamin D, but there is a very, very tiny detail that makes all the difference, is this. Vitamin D does not create any problem by itself. There are no papers showing that vitamin D by itself, the molecule of vitamin D, the hormone of vitamin D, will create any problem. It's always driven by calcium. Obviously, vitamin D will increase the calcium that is absorbed. That's true. That's why we have step 2 and 3, which is diet. So the goal of the diet is not reducing the inflammation that is triggered by the foods, it's just to remove calcium from the diet. So no dairy, or in the vegetable or the alternative milks in some countries like the US, UK, and Brazil that I know of, those vegetable beverages have to be enriched with calcium by law. So no dairy, no nuts and seeds, no green vegetable juices, and also no vitamin C supplements and no lithium. It seems to cause a problem in the kidneys. And also an increased hydration, at least 2.5 liters of liquids per day. And here we have a question of the calcium content in the water. It should be lower than 25 milligrams. And every country, we have patients from roughly 50 countries doing this treatment and being managed by us. And only in Portugal, we have water that is 100% compliant with this low calcium rule. Some countries have very low and very high. Some countries only have very high, like Switzerland, Austria, and, well, it's not a country, but Baviera, that area only have very high calcium water. Sparkling water is also a no-no because it has a very high calcium. So by doing diet and this hydration, this frost hydration, we not only remove the calcium that's entering the system, but we are also cleaning the kidneys. And this treatment is being more and more doctors have been trained by Professor Cicero. We are trying to come up with a plan to start training ourselves in some way or another. We haven't figured it out yet. We are waiting for plenty of things, but it is a possibility and we may be able to do so. So let's look into a couple of cases. So this third case was a patient that came with rheumatoid arthritis. And rheumatoid arthritis was diagnosed roughly 10 years before he came to us, after the birth of his doctor, and had joint edema in hands, in knees, pain, and he was taking NSAID, like Liproxen, for 3 times per day. And he had tried MTX and adalimumab with severe side effects. So he was, when he first came, his fatigue was very high. He had this joint pain and morning stiffness. And the initial blood work, we saw a very low vitamin D, you can see 11, and a pretty high, even though it was within the reference range, PTH. Calciums were fine, everything is fine. One interesting aspect is the 24-hour urinary calcium, because the 24-hour urinary calcium is, well, there you have, is the best marker to assess safety. It just measures the amount of calcium that our body is getting rid of. If we have too much calcium, we'll get rid of the calcium. If you don't have too much calcium, we won't. So it is the best test that anyone can do to assess it. And because his weight was quite high, 110 kilos, we started with 110,000 units plus omega-3, magnesium, and vitamin B2. And after 6 months, he had no fatigue, no pain. He needed no painkillers, and even his rheumatologist, who knew nothing what he was talking about, said that disease was in remission. And from a patient from the Netherlands to be able to cycle again, it's quite a very good result, since they live on bicycles, it seems. When we look into his blood work, we could see that vitamin D was very, very high, was unmeasurable, and PTH was right where we need it, which is below the reference range. But as you can see, the calciums stay pretty much the same, even though the 24-hour urinary calcium went a little bit up. So, and since then, it's pretty much the same. He has no problem. The disease is still in remission without taking any other drug. The fourth case is even more unique, let's say like that. It's a 53-year-old woman from the UK, ex-military, that was diagnosed in 2015 after the loss of her father. And he had hemiparesis, numbness, and she didn't try to do any other treatment. In the first appointment, had a very severe fatigue, and like a curiosity, fatigue is not a symptom of any specific autoimmune disease. It's a symptom of autoimmunity. It's a symptom of inflammation. So it's a very good clinical marker that we can use to assess if the treatment is being effective or not. Any treatment, not just vitamin D or diet or whatever. Its fatigue is very good. So her maximum walking distance was 100 meters and had lost the ability to write, and the signature was not that good. So initial blood work, vitamin D, not that low. In PTH, definitely not that high. Calcium's within reach. And we chose to start with 70,000 units because, I mean, she weighed 75, so we decided to round to 70. Again, the same omega-3 magnesium and vitamin B2. And after 6 months, she had very small improvements. Fatigue dropped from 8 out of 10 to 7 out of 10. Walking distance was 150 meters. I mean, it's still a 50% improvement, but nonetheless, in practical terms, it's not that different. The vitamin E, but when we look into the analysis, her vitamin D was already very high, but the PTH was not where we wanted, which is just below the reference range, or around 10 would be the ideal. So we adjust the dosage and we increased to 100,000 units. So after 24 months, I was doing the appointment through Skype, and she said, well, doc, do you know what is the Peaks District here in the UK? And I know fairly that it was a place, like a mountain place where it was people used to go there hiking. And she told me, I told her, yes, I know. And she said, well, 2 weeks ago, I went there with my mates and I could hike as much as they could without any limitation. And I was seeing my file and I was looking, saying, sorry, but here I have written that you could only walk 150 meters. And she said, yes, that's me. Sorry, what's your name again? She said my name. She had her name. It matches. And it's incredible how she could recover to a perfectly normal life. She had, after 2 years of treatment, she's now on the 4th year. She has absolutely no symptoms or any sign of the disease. So the Queen protocol, we go into these 2 different phases. The first one, we try to stop the autoimmune pathway, this Th17, and we use the clinical symptoms of fatigue, and heat intolerance always is also a good one. And it takes 6 to 8 months. And then phase 2, we don't know. It depends how much damage the patient has already suffered and what is recoverable or not. So in terms of lab testing, what we use in autoimmune cases is using the framework that I've just showed you, either the food sensitivity panel, any microbiome testing. I usually use CSCP. I think it's fantastic, but the others are very good with small differences depending on what we're looking for. The DNA health, we can measure the vitamin D, the PTH. It has to be through plasma, which is a bummer, but some patients can have it. And these urine essentials we can use to measure 24-hour autoimmunity. The 24-hour calcium levels. So just to finish, we can see that we have these 2 layers, which is the IL-17, Th17, this signature, and the vitamin D/vitamin D receptor. And we are missing the common factor. And when we look into the 4 cases, all of them seem to share something in common. The first case, we had divorced parents. Second case, MBA, post-graduation. Third case, birth of a daughter. Fourth case, loss of a father. And this is the last piece of the puzzle. The common factor is stress. All my appointments, I ask patients, what caused it? Why do you think it started? Why do you think you have it? And more than 90%, they tell me that stress was the cause or the trigger for the disease to appear or a relapse or flare. I wish I could tell you in more precise terms why stress plays so much importance. There doesn't seem to exist a clear understanding. What we know is that chronic stress reduces the amount of T regulatory cells that we can produce, and by definition it will mean higher autoimmunity, but we know that cortisol levels and a lot of different things can happen. So what I found over the years is that most of my appointments are just this, to breathe. And I walk through with the patients most of my appointments into discuss stress management techniques, and anything goes, whatever the patient feels is best for them. So this was what I was prepared or had prepared for you, autoimmunity from the gut to the sun through the genes. Thank you so much for being here. Thank you, and Catherine, too, for inviting me and for the amazing, amazing introduction. And yes, thank you so much.
Thank you, Miguel. You have kept 168 people steady for this whole hour. No one left in the end.
Oh, fantastic.
So,
thank you.
It seems like people loved it.
Thank you so much.
And of course, questions are coming up now, and they're all saying very good and thank you, wonderful, fantastic, doodle-doodle. Get it in, enjoy it. Some questions came up, and it probably goes a little bit on this. First of all, it was like, some of them were like how do you weight adjust and so on, and what do you do with children, and what do you do with people who's maybe only 48 kilos and so on. Yeah. But Miguel, you use, so one thing is measuring vitamin D, but the PTH is your marker, basically your functional marker for vitamin D. So Miguel uses that marker very much to if patient is getting enough vitamin D or not.
Yeah, so just a few words on that. So there are two different scenarios. One scenario is, can I prescribe safely 10,000 units to any patient without concerns with the diet, the water intake, whatever? And that is 50 kilos. If that, I don't know, ask about the 48. I mean, I'm 99.9% sure that 48 will not be a problem, especially because the chances are that person will have low levels of vitamin D. But I cannot tell that is 100% safety because what is the authority saying? So that is one thing. The second thing is when we start going on high dosages. And it doesn't really matter that much, the vitamin D level. It matters the PTH, as you were saying. It would be like if you have some kind of factory, like let's call a wood factory that's producing shares. And what will make the business grow is the amount of shares that you can produce. And the amount of wood that enters the factory is important, obviously, because you want the maximum efficiency. But what you will sell is the shares. And if you just look into how many shares are being produced and are leaving the factory, that will be the marker of success. You just need to tell the supplier to bring more wood. So what we do with vitamin D is looking into the end result, and that's PTH. When we look into PTH, it doesn't matter how much vitamin D the patient has. If PTH is low, it has enough. And we were able to achieve good results with people with 130 to 150 nanograms per milliliter vitamin D in the system, but have patients with 6,000 of vitamin D. So that each one of us are individual. I mean, I usually tell in another environment, but I usually tell if we are all different, why do we keep treating and approaching everyone in the same way. So we have our own genetic roadmap, and we need to address it. We need to address each and every individual. So looking into the PTH will be would be what will tell me if the vitamin D is being effective or not. Any other marker is not looking into the end results.
And then I want to take you on to the naturally next question would be, so how do you control that the calcium doesn't get too high? And I know you check calcium in urine.
Yeah.
You're controlling the patient all the way along every like 6 months.
Yeah, so
the calcium levels.
If everything goes according to the plan, which is most of the times, you have the initial appointment, the second is around 5 months into the treatment, and we have the appointments at the 1 year mark and the 2nd year mark. Because we don't, this is not a very, for one vitamin D takes at least 2 months to go up, any dosage to go up, stabilize, and have clinical results that are sustainable and that we can measure in the blood. So I give usually 4 months because patients go out of the office, they take some time to make the blood results, and then they order supplements and everything. It's usually a month before they start the treatment. And just to make sure that I will have the proper results, I wait until the 4th, 5th months of the treatment. But we keep everyone, every patient of mine leaves the appointment knowing that the risk is dialysis. And that usually makes it. They usually get very attentive to it. So they manage their own safety by knowing what they can eat and what they have to eat. And then we go from that and we adjust the dosage depending on the fluctuations of PTH. And we always look into the calcium in the urine. And it's very, very, very rare that we have any problem. I mean, you have more than 500 patients under active management now. And we have 4 cases of very high hypercalcemia with mild to moderate kidney impairment. All of those patients recover completely, so no medium or long-term damage. But all of them, apart from one of them was caused by lithium that he didn't disclose to me that he was taking, and he was already doing the protocol when he came to me, but that's why I didn't know. And the other 3 was because they didn't comply with the diet and hydration. So as long as our patients keep doing what they are told and they agree, the treatment is very, very safe. In children, we have children doing it. And actually we have some children with autism doing the treatment because it seems that some part, a part of the autism can be autoimmune. The problem with autism is, the problem with kids is, one, they are very hard to control, and it is the parents' duty to make sure that they drink the water and comply with the diet, which is tricky. And second, they grow, so we need to adjust the dosage more often. But other than that, in theory, the treatment will work with children. And the youngest child we have, I think it's a 6-year-old now. She is from Angola, and she had vitiligo, and clearly it was very visible, and she recovered completely, which is fantastic.
Excellent. I think just a few, that's one that I think is important, because I have had a patient where I had to ask you the same question. If a patient has osteoporosis, they need calcium, how do we handle that on this?
Fantastic, yes. So, osteoporotic patients need to have optimum calcium levels. In the protocol, they will have the optimum calcium levels because vitamin D will optimize the absorption of calcium from the diet. So you just have to think that in the gut, the doors for the calcium to enter will be wide open. So we have enough calcium in the healthy diet to fill our needs. We have everywhere we have calcium. So we optimize it. So patients with osteoporosis cannot take calcium supplements, but they will not need to take them because the absorption will be optimized. Now, vitamin D also one of the effects it has is increase the bone turnover. And in this process of bone turnover, the osteoclastic and osteoblastic actions may not be perfectly coordinated. And in some patients, some bone loss can exist because the construction works slower than the destruction. And it is quite a concern of ours. And it usually women that took a lot of corticoids and that cannot move that well, those are the ones that usually suffer from osteoporosis. And in those patients, we either put them on boron, K2, vitamin D, increased magnesium, or in the worst case scenario, we'll have to go into a pharmaceutical drug.
Okay, thank you. So then,
sorry, let me just interrupt because we have a question that I was confusing. Sorry, I was a bit confused. And now this will optimize the calcium absorption on the diet if the protocol diet seeks to remove most sources of calcium. Yes, that's okay. So I was confusing in this part. Okay, so if in the diet, we don't remove all the calcium. We removed 3 very specific sources of calcium that are very identified: dairy, nuts and seeds, and green vegetable juices, not green vegetables, just the juices. And we can think of how much spinach we have to juice to get a glass, right? So the calcium gets very concentrated. So the diet will have enough calcium to supply our needs. Because vitamin D will optimize the absorption, the calcium that you eat will be 100% absorbed. So instead of without vitamin D, taking calcium supplements will be roughly, you will be enriching the calcium on the sewage because it will not be absorbed. But think about absorption of 5, 10, 15%. With high vitamin D, the calcium that you ingest, you eat, will be absorbed 95 to 100%. So it's just more efficient absorption of calcium, and that's the reason why patients will not have low calcium levels. We have 3 patients out of the 600 that do need to actively eat calcium to maintain the low levels. Other than that, we don't have any problem.
So K2, riboflavin.
Okay, so K2 is very straightforward. Indeed, there's a very known effect of K2 and vitamin D in terms of calcium. So simply, K2 picks up calcium from vessels, usually, and puts it in the bones. However, that effect seems to stop around when we go higher than 40,000 units. And we know that there are some papers that seem to show it, but when Professor Coimbra tested including K2 in the protocol, when he was developing the protocol, he noticed no difference in the peptides for both osteoclastic and osteoblastic function, or even the DEXA scan showing any improvement. So we do use K2 to try to have some effect to prevent usage of pharmaceutical drugs like bisphosphonates. We all know how damaged they can be, but it's not a staple in the protocol. It's after 40K, it seems to go away. And it's by the way, the dosage should be 100 micrograms of K2 MK7 for every 10,000 units. In terms of the B2, B2 will help. So B2 is a co-activator in the enzymes that activate. So B2 is a cofactor on the enzymes that activate vitamin D. So we give K2 trying to make sure that the enzymes will work in the best way possible. There are more than 20 studied. There are more than 20 places in which these single nucleotide polymorphisms can influence the efficiency and effect of the vitamin D. VDR is the one that is most studied, but they are in the 2 hydroxylases, the vitamin D binding protein, the transport. I mean, everywhere can have. That's why we look into the PTH, and there is we don't have any direct correlation of these results. Any results will lead to this resistance and this dosage. So that's why we depend so much on the PTH.
I think that's it.
Perfect.
We come to the end.
Okay. Thank you so much for your time. Thank you so much for being here. Thank you so much, Anne Catherine, for the invitation and the introduction. And it's my pleasure to share this with you.
Thank you. So here you can clearly see we have someone who lives and breathes and was bred on functional medicine.
Yeah, I forgot to comment on. Yes, the first course that my mom did on while she was finishing the degree in medicine was of acupuncture. She was pregnant of me, so I have it is through no fault of my own that I'm here. I was born into this. So, and that's what I always try to share is from a built-in system that I was born in, and that all my training in functional medicine was in my dinner table, day in, day out. My mom would share clinical cases and I would arguing and thinking about possibilities, everything. That's my training, and what it built in me was this series of questions and to think why in a more Latin and Portuguese way or not. And because I'm kind of lazy as well, I try to see patterns everywhere I can and try to help me figuring out this is one step forward, one step backwards. Okay, so this is the pattern on diet, or is the pattern on, to make it more sustainable, even from the attention point of view. I want to make it as easy as possible and the least overwhelming as it can be, as you so well know, and everyone knows, worked in this area, leading with so much information, so much hypothesis. Where do we start? And that's what I try to share to people, is how my brain works step by step and all different possibilities.
So Miguel mentioned several tests. Most of them you can all find in Nordic. You can prescribe it to your patients as one order. Remember, we drop ship. The Nordic food panel, Miguel elegantly demonstrated in Portuguese. You can get it in English, you can get it in Danish, you can get it in Swedish, you can get it in
Icelandic.
Icelandic, yeah. So yeah, just choose the language you want it in. Stool tests, there are different stool tests. The one Miguel demonstrated was the CSAP ×2, but you can use a GI map, which you will get more training in 2 weeks' time. And we already have had some training, so you can watch the videos if you wish to. DNA Health is an amazing tool to find out about the vitamin D receptor function. And it was even praised in the comments by one of you. So yeah, I can only highlight that one as well. And vitamin D we get as a blood spot test. The Nordic Food Panel is a blood spot as well, so it's easy for those where you don't have to do blood draws, and you can have it drop shipped to the patient. They do the collection at home and they ship to us, and you get the results. So it's the only one is PTH, which is a blood draw. So that needs to be coordinated, but we drop ship the kit, and if the patient can find a phlebotomist or have a sister or something like that who can help them draw the blood, then we can work on that. And essential elements would be the test of choice in our system to check up on urinary levels of calcium, to check that there is no too high levels. So yeah, just to highlight that as well. And the vitamin D that Miguel really likes is, I wrote it in the comments, it's if you under supplements or write 10,000 IU, it will come up. And I can't remember if it's a dot or a comma, but it's there and it's to work with. So then just a last question here is in regards to COVID testing. Yes, we offer stool, SARS-CoV-2 in stool. We do offer the NP swab as well, but only for doctors. And then there is a blood antibody, full blood draw antibody test in the system as well. So yeah, you can order those for your patients as well. So I'm just being lost a little bit about the insisting here. Someone is asking about the training, but from the conversation we had earlier, there's a little bit of confusion about training. And we don't really know anything right now.
Yeah, so the thing is, Professor Coimbra is quite brilliant doctor and researcher and a neurologist, and he's a very good man. And as all very good men, they are taken advantage of. So what happened is he, very early, like 4 years ago, a person from a non-medical doctor or non-medical anything in this case, convinced him that he could do the treatment and ask doctors to prescribe analysis. So here the key is to have very easy access to analysis. And even though we can use the vitamin D blood spot and PTH, it is from a Dr. Coimbra, Professor Coimbra point of view, we need to have very easy access to regular labs in case of emergency. So that's the real issue, is if a patient has toxicity, how easy and how quickly we can access it and treat it. Because that's, at the end of the day, that's what will make it or break it. So because that experience with that gentleman did not go that well, he only accepts medical doctors in his training. And the training is free, no charge. They just have to fly to São Paulo. Not the most beautiful city, but you fly there, you have obviously to book. I think it's at this stage a year and a half in advance. So that's why we are trying to come up with any type of training in Europe. That's what we are trying to. We are in the very early stages. We don't know if and when it will happen. So keep, when we know, we'll share it and we'll let you know. But at this stage, we don't have any specific date to it. So it is a very good possibility, but nothing more than a possibility at this stage.
With that, Miguel, I think this is it. Thank you very much.
Thank you.
From my heart to you. Thank you. And virtual hugs and everything.
Yes.
And hugs to everybody who stayed.
Yeah.
The next topic will be fasting mimicking diet, a prolon, an important component in our functional medicine toolbox. I think I might be the one who does that one, but yeah, let's see. Yeah. I invite you all, and we will send out invitations for that. And then in 2 weeks' time, we're back on GI Map. What's interesting is I have had some requests from practitioners saying a little bit that the levels are really high and they really love these webinars, but they also want like more basic training. So we may start doing a little bit of that, but it's just on the drawing board right now. But thank you for today. Thank you, Miguel. Thank you, everyone. See you hopefully next week. Same time, same place. Bye.
Thank you. Bye-bye. Thank you.